Good morning, America. This is the Cats Roundtable, and this is John Katzmatidis, and it's Sunday morning. And we deal with a lot of remarkable things on this show. This morning, there's a new cure for leukemia. And with us this morning is Dr. Mark Souweidane. Mark Souweidane is the Director of Pediatric Neurosurgery at Weill Cornell Medical Center, and he's Vice Chairman there. He's also in charge of pediatric neurosurgery. Good morning, Doctor. How are you this morning?
Good morning, John. I'm well. Thank you very much.
Tell America about this new thing that the FDA has approved last week.
Yeah, this is fantastic news because it certainly lends credence to a principle that has been explored for a while now. And essentially, what this agent in therapy offers is a formalized way of what we call harnessing and utilizing the intrinsic immune system of the individual, in this case the child. The immune system is what is typically used to ward off infections, and to use that system to now eradicate cancer cells and go after cancer cells and kill the cancer cells based on a honing mechanism.
That is remarkable. I would say almost every American would probably say the same thing, that we reprogram these cells to go in and kill the cancer cells?
Yeah, and the reason there's many features about it that make it remarkable, but I think the scientific and biomedical community has been very engaged in this concept for some time, and it affords the patient really unbridled advantages relative to the way we've typically treated cancer. The typical approach has been essentially an A-bomb dropped on every cell in the body, hoping that you can have the cells that are needed to be preserved recovered in such ways. These types of adoptive T-cell therapies, is what we're talking about today, program the cell to have probably the best specificity ability in cancer therapy, so that it's not everything in my path gets damaged, but the cell itself, which is called cell-based therapy, seeks out the tumor cells individually and attacks them individually. So it preserves every cell you want to preserve in the body other than the cancer cells.
Not like, chemotherapy, which damages every cell through that. Is that correct?
Yeah, and that's always been one of the limitations of utilizing chemotherapy. And chemotherapy, by and large, there's very effective agents out there that are extremely good at essentially killing dividing cells. And we know in most cancers, the way you differentiate cells you want to preserve in the body and the cells you want to attack, namely the cancer cells, are differentiated based on how quickly they divide. Hence, the cancer, it grows very rapidly. So that's been, by and large, the only specificity built into most chemotherapeutic approaches. Dividing cells will get killed by the chemotherapy. But when you flood the body with high levels of chemotherapy in the hopes of getting those cells, the byproduct is other cells that are dividing, skin, hair follicles, intestinal tract, kidney, these organs, bone marrow, a big one, all of these end organs get affected in an equally potent way. So then what we have ended up doing in that approach is trying to treat the byproduct of our initial cancer therapy.
Is this a first step in a whole new field of medicine?
Well, it's without question a great step in an amazing direction. And I think it's a wonderful testimony that the FDA has granted approval in this breakthrough status for this type of therapy. There's much enthusiasm built on the concept, as I've mentioned before. And why? Because you're using the body's innate tendencies and talents and abilities to attack cancer cells. So nothing sounds more appealing, right? Rather than flooding the body with cells that are matched from a different donor, or rather than utilizing chemotherapeutic agents that have no business being in the body, this is utilizing cells that we all have and just need to be trained to go after the right cells. So if immune therapy or immunotherapy or immune modulation, if these turn out to be beneficial to the patient, there's really limitless potential here in preserving the well-being of an individual and specifically going after cancer cells. Now, I've painted a very simplistic view, but there are great challenges in rolling that out in a clinical enterprise.
Now, if a child came in to see you tomorrow or next week, how do you pick which one of the two, chemotherapy or this new treatment?
It's a great question, and it's very dependent on many features. Given my specialty in pediatric brain tumors, obviously it's a much different set of therapeutic endeavors or options that are available to that child versus, say, a child with ALL or acute lymphoblastic leukemia. So disease specificity and disease type play a very major role in determining which therapeutic agent to use or agents to use, which are responsive to radiation therapy, which seem to work well with a specific type of chemotherapy. Is there a what we call targeted agent that does have that selectivity available for that type of tumor? So most of this is governed by practice. From the standpoint of a lot of the information that we know about effective therapy is born out of typically what we call cooperative group trials in North America and throughout the world, where because of the rarity of these diseases, we come together with the different institutions to set forth certain therapeutic plans and strategies, test those against the conventional, and try and accelerate the advancements that are made with new therapeutic designs. So those trials are well known. Those are always ongoing and available at most legitimate children's hospitals in North America.
Now, this new product, the Kymria, I understand it's a very expensive product. Does that come into play at all when somebody comes into the hospital?
Not particularly. It comes into play typically when it's being offered outside of the realm of a clinical trial, and that's where the challenge comes. Or when something's being used what we call off-label, where the FDA hasn't necessarily approved it for a certain disease or indication, but there's a desire by the patient, the family, or the clinician to utilize that agent for whatever reason. So in the context of most clinical trials in the United States, that doesn't play a large role from the standpoint of affordability. And the reason is because most of these trials, when they're designed, when they're implemented, there's not an equally strong, but a proportionally strong interest put in funding that clinical trial to make sure it goes through the normal processes of satisfying its goals. So that is done through grants through the federal government, the NCI. That is done through external foundations, external funding sources. That is done through gifts and donations, but and also through industry. Obviously, pharmaceutical industries have a very vested interest in pushing some of these platforms forward. So in the context of clinical trials, even though they're costly, that cost is usually deferred to other sources other than the insurance company or the patient themselves.
Now, in your knowledge, this kind of modification of gene therapy, if those are the right words, what other areas are they working on right now?
In addition to gene therapy?
Gene therapy for other cancer diseases.
Yeah, I mean, the horizon is expansile. It's limitless, right? This is really governed by the level of funding to drive some of these platforms forward. The conceptual basis, usually what happens in situations like this, like we're seeing with this most recent approval, ALL being the most common or one of the most common cancers in children, we hope will pave the path for exploring that option in less common tumors. The more rare a tumor or a cancer, the more difficult it is to push an innovative therapeutic platform forward because of the funding issue. And that makes sense from the standpoint of the impact on society. And obviously investment is made on larger numbers. When we and myself and individuals that I work with have an interest in pediatric cancers, that gets diminished rapidly just because of the fewer and fewer numbers of children relative to adults and the elderly with certain forms of cancer. So for obvious reasons, the funding that feeds into this usually is predicated in large part by the sheer number of patients that it affects, rather than the unique and rare tumors that we're sometimes forced to deal with.
Understood. The unique and very rare ones cost more because there's less patients to allocate it to.
It's not only that they cost more, but these certain amount of funds that are allocated aren't proportionally put into those buckets or those types of indications because they're so rare. So the return on that investment is not as great, whether you're talking about from industry or impact on society.
There was a report last week that the Zika virus can kill brain cancer. Have you heard much about it?
Yeah, it's revisiting another platform with viral-based therapy for cancer, and this is again not a new concept. And different viruses have different advantages when we talk about using them for cancer-based therapy. And there are a couple of ways that viruses are used for cancer-based therapy, but the most common concept is that virus has certain specificity, and you can program that virus to have different specificity. So when you get infected with the flu virus, it might have a specificity for respiratory and nasal mucosa, the linings of the airways preferentially. So that's a specific honing in mechanism of a virus. So the platform and the concept is quite appealing. You take a virus, you retrain it to infect certain cells, and if you can train it to attack tumor cells, then you can package in that virus a multitude of things that will serve as the detonator, if you will, for the cell to die once it's infected by that virus. So oncolytic viral therapy is quite a common principle that's been explored, but there are clearly challenges that are met with that, as you'd expect. Viruses infecting cells they shouldn't infect is a major one. The limits of what you can put in a virus to hone in on that specificity, and trying to define what those signals are on the cancer cells that you can train these viruses to go after. So it's very similar in concept to what we're talking about with adoptive T-cell therapy or utilizing these CAR T-cells, that you're training these live organisms, viruses or T-cells, to go after tumors. And the reason both of these platforms are extremely appealing is because of the idea that if you can use genetically engineered or gene therapy training of a inherent T-cell, then it's very simple to think that you don't have to redose with more chemotherapy or more cells. So now you've trained the body with these living cells to continuously basically go out and scout the body and attack those cells that are specifically aligned with that T-cell or that virus.
Well, thank you so much for what you do for all Americans and for all humans. Dr. Mark Souweidane, Vice Chairman of Neurological Surgery at Weill Cornell. Thank you for your remarkable work, and thank you for being with us this Sunday morning.
John, I want to thank you as well for bringing this to the attention of your listeners.
Thank you.